Good afternoon, everyone. Welcome. My name is Pam Schaff. I'm the director of the HEAL program, Humanities, Ethics, Art, and Law program here at the med school, and of the Master of Science in Narrative Medicine program. How many first-year medical students do we have today? Welcome. It's great to see you. As HEAL director, you're going to meet me again on Monday in the EPIC course, so you'll learn more about HEAL. But this is part of HEAL. This is part of our Art and Medicine program. And today's event continues HEAL's mission to align the work of artist patients with the core medical school curriculum and to enhance understanding between patients and future health professionals. And today we're very fortunate to have one of our own physicians, Keck physicians here, Dr. Marcia Ciccone, and she will be in conversation with our artist patient, who I will let Ted introduce in a moment. Ted Meyer is Keck's artist in residence, and he is responsible for curating these shows that are in the gallery space, and you'll get to hear more from him over the course of the year as well. But now I'm going to turn things over to Ted and have you introduce our artist.
Hi, everybody. Welcome to all the first years. We're very excited to have you here. You've got some hot weather, but it will cool down, and you will love it here. I want to start by saying, because this is endometrial cancer, I obviously am not an expert in this subject, so I'm going to be relying more on a discussion between these guys. I will prompt some questions. I'm going to lean more heavily into the art end of it on this conversation. So I've known Karen for a long time as part of the LA art scene, and when we first met, your connection to the medical world was on the administrative side. So you have been on both sides. You were a lab tech and a phlebotomist in the 80s, and then she started working in policy and later in patient accounts. So I'm sure you have some stories, and we will talk a little bit later about the difference on being on the billing side or the build side of this. You were first diagnosed in 2020 during COVID, and I'm sure you can talk to us about having to deal with that time frame. And what I mostly noticed, I would see you out, and I could tell where you were in your treatment by how many wigs you had, what color the wigs were you wearing head wraps, was your hair coming back in, and I could sort of tell, oh, she's going through chemo, or the chemo's over and the hair is coming back, and then all of a sudden the hair disappeared again and there were more wigs. So, with that in mind, tell us about the title of your show.
Okay, well, the title of the show is Advanced Recurrent because they don't refer to us as stage 4. we're advanced recurrent, which means my endometrial cancer, 75% of which is usually cured with just hysterectomy alone in most people. I was lucky enough to have it come back, which is the recurrent part. The advanced part is that the first recurrence spread outside the immediate area. So I had a lesion in my spleen, I had some lesions on my abdominal wall, I had a lesion at the vaginal cuff. This talk is not going to be for anyone squeamish about female anatomy. There's going to be a lot of that. So yeah, we're a little, we're just referred to a little differently. So, and my cancer is still technically incurable. Right now I'm no evidence of disease, I'm in remission. But that doesn't mean it can't pop up like whack-a-mole. You know, every couple of months, every couple of years, it's not considered a curable disease.
Let's just talk about wording, because one of the things we talk about a lot with patients when they're up here is medical terminology versus real-world terminology. So at the moment, you're cancer-free, I guess would be, but you're still considered.
Right. Yeah.
Why don't you talk about just vocabulary that maybe our students can remember when talking to people and have horrible sounding things that are really okay?
Well, it was actually a little bit easier for me because I've spent my entire adult life working in healthcare, in the medical field. I know the terminology. I can read my own pathology reports. I can, so none of the terminology was unusual for me. And, I like language to be precise, but I can certainly understand how patients coming in who have not spent their entire lives working in hospitals, around hospitals, working for doctors, are, have these terms thrown at them. I think it's just really important with patients to be clear, to use appropriate terminology and explain that terminology to people who don't, know it as well as I do.
A lot of times on these talks, I start with specific numbers, how many cases in the States. But Karen had sent me this chart, and I've become really interested lately in sort of the increase in cancer in young people. And so I just thought I'd put this, without going into specific numbers, but are you finding more younger people showing up? Or are you finding...
We're definitely finding, especially with endometrial cancer, and you can clearly see in this graph that the rates are increasing. We do see endometrial cancer in younger patients. It does, of course, depending on exactly what type, tend to be more common, of course, in older women and women as they get older. In terms of if we're actually seeing younger women more frequently, I don't actually know if we're seeing younger women more frequently. I know we're definitely seeing older women more frequently, and we're seeing more aggressive endometrial cancer in the last few years. And it's even something that's noticeable, not only statistically, but like anecdotally in the population that we see. It's becoming very heavily endometrial cancer.
Yeah, and in some of my own, looking at statistics, endometrial cancer is the most common of the female cancers, but it doesn't get the attention that cervical cancer or breast cancer or any of the other female cancers get. It's a little more under the radar, and I think that may be because it does primarily hit women over the age of 65, and at least according to some people in the current administration, we're basically useless at that age unless we're babysitting grandchildren. So, yeah.
I could go on forever, but I'm not going to. All right, so let's talk about your artwork up there and jump in whenever you'd like. This piece sort of is a good starting point because it has a collage with things from your old days of working on that side of the medical world and things from your patient side of the medical world. So why don't you talk about this one?
So this piece really speaks to seeing the patient underneath all of the paperwork, whether it's electronic or on paper. You still produce way too much paper, but underneath all the bills, all of the pathology reports, the surgical reports, the assessments, there's a human being under there. And cancer care has become, the advances are insane. I mean, it's absolutely amazing. But sometimes I really do feel like I'm on a conveyor belt in a Ford factory, and I'm just going from that doctor to that procedure to that doctor to that procedure and that doctor to that procedure, and God forbid the three doctors should ever speak to each other. So I'm telling Dr. X what Dr. Y said, and saying, read the notes. I read the notes. You should read the notes too. So it's and I think for the medical students that's really important. There are people underneath all of this stuff, and your job, I think, as physicians, is to make even the briefest, smallest connection with your patients, so that you see us as human beings, and we can see you as human beings.
So this piece, you told me it's your favorite one, and I love the title. And why don't you talk a little bit about the anxiety as the patient? You're supposedly cancer-free at the moment, but you still have these scans, and every time you have a scan, which is every 3 months now?
Just moved to every 6 months.
Okay. So every time one of these deadlines shows up, there's that fear of recurrence. And then maybe you could talk about what you've seen with your patients and what they go through, knowing that every scan could be a new diagnosis.
So this piece is called scanxiety, which is a term bandied about by a lot of cancer patients in support groups and things, and it's the anxiety surrounding scans. Scheduling scans, waiting for scans, not necessarily having the scans. The scans are easy. And then waiting for results from the scans. And due to a fairly recent law, scan results are released to patients as soon as they're available. I know how to read them, which kind of makes it worse because I can interpret them. But there is just a lot of anxiety around scans. And this piece was based, the composition is based on a painting by Frank Kupka, a Czech artist. And I just kept looking at that composition and like, why am I so attracted to this? And I was like, oh, it looks like the entrance to a CT scanner. So this is my little trip into the tunnel of the CT scanner. And as I said, I just moved from scans every 3 months to scans every 6 months, and my first scan in 6 months is on Friday. So the scanxiety is kicking in.
So we're hoping that gets relieved soon and you get your results and everything is good.
We're hoping.
Yeah. This is a very impressive piece, actually, and I don't know that it does it justice to see it from afar because you can see all the details up here with all the scans and all the other things that you have like underlying. It's very cool.
That's another thing to be prepared for. If you have patients who are artists, we will ask you for art supplies. Sometimes we will steal them. I asked my radiation oncologist if he had any radiation oncology journals, and he walked out with a 20-pound stack of books I had to carry to my car. So the background of that piece is scans cut out of medical journals, and don't leave sharp instruments around us because they're really good art supplies.
Yeah, definitely I can see with my patients also that scanxiety is a thing. There's prescribed ways to follow up patients, and of course, while you're on treatment, we always want to get routine scans to make sure we're not giving you something toxic that may not be working. So we always want to monitor very frequently. Usually that's about every 3 months while our patients are on treatment. And then typically for different cancers, sometimes there's prescribed scans, sometimes there's not, depending on, what the risk level is and what that person had to begin with. You're a little bit in a gray zone in the zone you're at because it's not, the standard follow-up. It's great that you are cancer-free, but it is a little bit of a gray zone in terms of how to follow things. And so the longer clearly you go without having a recurrence, the better. And the less frequent we have to do those scans, and just like anything, they have consequences. Not only of anxiety, but of potential, secondary problems from them. So we don't want to do the scans too often, but definitely, anxiety coming up to it, anxiety, like you said, after the fact, and I can't tell you how many patients message me, when their scans don't come in yet, because we don't get them until the radiologist reads them. So the patient may have their scan done, but if the radiologist hasn't read the scan, then you don't know the result. I don't know the result. And so sometimes if it's like taking longer than normal, I'll have a lot of patients message me, there's something wrong with my scan. It's not back as soon as it normally is back. And then I end up having to explain to them that, the radiologist hasn't read them yet. They're taking a little bit longer, et cetera. But then there's the anxiety that comes also from like incidental findings on CT scan, which you've probably run into at this point. And those are things like small lung nodules or pulmonary nodules that we frequently see that honestly just occur as a result of living in Los Angeles, breathing the air, having prior respiratory infections. And so we see those so frequently, but if you're a cancer patient and you see, I have this pulmonary micronodule, you're like, is that cancer? What does it mean? Or the same thing with like cysts on the liver or the kidneys, or sometimes things just kind of show up in the bones, and a lot of these things are nothing, but sometimes they lead to other procedures, other biopsies, other things that also can be anxiety provoking. So there's a lot of reasons, in addition to, oh my God, the main one being, is my cancer back, that these scans are and can be anxiety provoking.
So you had 2 rounds of chemo? I'm not exactly sure how it works.
No, I had 1 round of chemo. I had six treatments of carboplatin and Taxol. And with the 4th treatment, Keytruda was added, immunotherapy, which had just been approved for my kind of cancer. So that was added in the 4th cycle. Okay. And then I was on that for close to 2 years, and then eventually with Lenvima added, which is the one that caused all the damage. Nasty stuff.
All right. So your show is slightly different than a lot of the artist shows we have, because a lot of the artists do general work about their whole condition, whereas you're sort of a storyteller, and each piece is about something that happened, and there's descriptions next to all the artwork of what happened with her. So maybe you could tell us a couple of the stories, because some of them are pretty funny, although macabre.
Or both. So this piece is called Achy Breaky, and one of my treatments was brachytherapy, which is, I had done as an inpatient procedure, which is amazing technology. Needles are inserted directly into a tumor, and you're taken to the radiology suite a couple times a day to have radiation blasted directly into the tumor. Except these needles are embedded in the tumor, except they go in through, in my case, went in through my vagina. So I was flat on my back in a hospital bed, spread-eagled with my legs tied down. I'm a side sleeper. The worst part was sleeping on my back for 3 days. And, couldn't move for 3 days. They transferred me from the bed to the table and back to the bed. And my left brain is saying, this is really, really amazing technology. Who invented this? This is brilliant. And the right side of my brain is saying, he sounds like he's describing a crime scene. The victim was found, it's just, and what monster thought this up? Had to be a man. No woman would think this up. So basically, brachytherapy involves a lot of sharp, pointy things. And so hence a lot of sharp, pointy things. And the white part is, again, oncology journal articles coming in to target that tumor, and it worked very successfully. Yeah.
All right, the deluge.
The deluge. So this is kind of like the first piece in the series. This is more abstract. It's everything is going along fine. I've retired. I get to make my art. I get to travel, and then, I get attacked. Especially after 3 years after my initial surgery. I was discharged. I was told, go home, go back to your GP. You'll be fine. And then 3 years later, out of the blue, I had my first recurrence, and and even while I was going through it, first getting symptoms, which were mostly GI and bizarre abdominal pains, it never occurred to me that it was my cancer back. Just thought, this is gastritis, which is what I was initially diagnosed with. There was something else. It just never occurred to my pea brain that it was my cancer back.
Yeah, I'm going to say that I think recurrence is more devastating and scary, for sure, than the initial diagnosis. Maybe because you know what's coming, maybe because it's less likely to be curable. But recurrence is a very scary thing.
So this is a good time to talk about when people first come to you. What, if somebody has this sort of cancer, what brings them to you? What are the symptoms that they're finding at home that makes them call you?
I mean, typically for endometrial cancer, it's vaginal bleeding. And of course, in women who are postmenopausal, that would be postmenopausal bleeding, which at any time, and just for PSA, for everybody, I think we need to, make a very public announcement for this, and I wish every woman knew this. But even a little bit of bleeding needs to be checked. For premenopausal women, it would be heavy bleeding, irregular bleeding, just periods that change in any way, especially for women in their 40s, especially for women who are obese or overweight. So typically, a woman would come in with abnormal bleeding or postmenopausal bleeding, and we work that up with an endometrial biopsy and usually an ultrasound. There were guidelines that changed very recently in the last few months, actually, that now say you should biopsy any woman who has postmenopausal bleeding, no matter what the ultrasound shows. So it used to be if the ultrasound showed a thin uterine lining, that you didn't necessarily have to do a biopsy unless the bleeding persisted. Now they're actually recommending that everybody with bleeding get biopsied, and I think the reason being the fact that endometrial cancer is increasing. So when a lot of these women come in to see GYN, or us as GYN oncologists, many times they've already had biopsies with their general gynecologist, and those biopsies have already showed the cancer. But they haven't gotten to have those discussions about what comes next. And so a lot of women walk into my office with this diagnosis, very anxious about the fact that they have cancer. And fortunately, for most patients, like you mentioned earlier, this is a very curable diagnosis. This is something that oftentimes only requires surgery. But it is a surgery in which we actually get a stage, and we do need to determine if there is more treatment that's necessary. So I'd say, 70 to 80% of women that walk in with kind of the run-of-the-mill, low-grade, grade 1, grade 2 endometrioid cell type, because the cell type really matters in this cancer too, are going to have an excellent prognosis with just surgery. But there are times when I think, and this was the case for you, there are more worrisome pathologic features, such as deep invasion of the tumor into the wall of the uterus, spread into the lymphatic channels, spread to lymph nodes, and that's one of the things that's important for endometrial cancer surgery, is checking out those lymph nodes and making sure that we're not dealing with something that's more advanced than kind of, like I said, our run-of-the-mill endometrial cancer, and a run-of-the-mill, like, early stage. And so, for the most part, most women feel better after they come in and they see me for their first visit, because they feel like they see a path forward, they understand what's going to happen, and they're like, we're going to get this out soon, So I think that's how the first visit usually goes.
Yeah, the time between the diagnosis, which again is usually with your regular GYN, and just a little PSA, the single most painful procedure on the face of the planet is an endometrial biopsy, and they do it in an office with no anesthesia. Ask for anesthesia.
I have some comments about that too. Ask for pain medicine and get a block.
But that time in between, I remember I was sitting in the parking lot outside an EPIC meeting on the phone in my car trying to get an appointment with a GYN oncologist after my GYN had found the cancer. Yeah. No, it's that waiting period, which now is increasing. I just read a study yesterday that the wait time between diagnosis and first treatment in all kinds of cancer across the country has increased by 10 days over the last 5 years. And those 10 days mean a lot to us.
On that happy note, this next story that goes along with this piece is one of the better bad things that a doctor could say to a patient. So I will let you tell this story.
I won't mention any names. So this really speaks to trying to make a human connection with your patients. We all have different personalities. Hopefully you go into a branch of medicine that fits your personality as well as your interests and your skills. But a lot of physicians, like a lot of regular people, are socially awkward and don't really know what to say to patients. This is an example of that. So obviously I have to have regular internal vaginal exams. 2 of my 3 oncologists do them. My medical oncologist doesn't, my radiation oncologist does, and so does my GYN oncologist. Radiation oncologists are not trained in doing that. They just have to do it to check for radiation damage. So I'm getting my internal exam, and he's explaining the radiation damage he sees, and it's normal and nothing to worry about. And then he says, but it certainly doesn't look like it did 20 years ago. Which I just thought was the most hilarious thing I'd ever heard in my life. I really think you need to put seatbelts on those exam tables, because I almost fell off laughing. But my thoughts are going right away to, this man was not all up in my business 20 years ago, and 20 years ago I think he was in the 6th grade. So this is This piece is called Not Like 20 Years Ago, and the top piece is, again, my one of my reports from one of my exams.
Things you should not say during pelvic exams. Note.
But it did make him more human to me, so it actually did help. It might not go over the same with everybody. This piece is called Am I Blue? And again, it's just another example of my weird artist brain at work. My first medical oncologist, who was at St. John's in Santa Monica, Dr. Kim Margolin, who's the only name I mentioned because I absolutely adore her. But she would bring in journal articles for me when I would see her. Read this study. This just came out. And she would give me copies of the Journal of Clinical Oncology when she was done with them, for art supply purposes. And I was going through them, and all the ads are blue. This big, fancy oncology journal, Sirius, they have a brand. They've picked blue. Why? Is blue calming? Is blue supposed to keep us all calm when we're reading about this stuff? There's no red articles, except for Keytruda, which their ads are all green and fitting with their brand. And so I just know that it's Merck, isn't it? Paying a boatload of money to get their green ads in JACO. So this is called Am I Blue? Because all the ads in JACO are blue. Clouds got in my way. So people here who know me know I'm a planner. There are spreadsheets for vacations, all of that. And nothing happens unless it's on the calendar. Having recurrent cancer throws all kinds of monkey wrenches in all kinds of planning. Every trip requires trip insurance because I don't know if I'm going to have to cancel at the last minute. So I never know when something's going to come back, and all my plans are going to be disrupted. So this is just speaking to, trying to stay on a path, and you won't hear me use the word cancer journey because I just abhor that. But trying to live on a normal life path, and then having the clouds come in and obscure everything again.
So as somebody who is very organized and does a lot of spreadsheets, talk to these guys a little bit about time management to be sick. And you can probably add here, because sometimes people think, oh, I went to the doctor and that's it. But you've got all the other treatments, and especially if you were younger and had kids at home, you'd have to deal with shuttling them around to school, and maybe there's a grandparent in the house, and you have all these new time things. I don't know how it works as far as taking medicines at specific times, but just talk about having this illness and managing your life.
Yeah. I think one of the best choices I made was transferring my care to a comprehensive cancer center. I'm currently treated at City of Hope. So everything's on one campus. So at least that solves that part. I don't have one doctor here and one doctor there, and there's 40 miles of traffic in between. Schedulers are your best friends. If you're a patient or a doctor, be nice to the schedulers. They work so hard. Like if I have, I have a scan on Friday, and then I have some routine maintenance stuff that I thought had gone by the wayside, a mammogram and a bone scan next week, and they went out of their way to make sure they were both on the same day, so I wouldn't have to make 2 trips to the campus, even though it's fairly close to my house, So, but managing time, you really have to explain to your patients what this all involves, what kind of time it's going to take. My external radiation, which was done after my initial diagnosis, after my hysterectomy, was in Santa Monica. And I just lucked out in that it was during COVID. So I had to go to Santa Monica from Pomona, which none of you know where it is, but go out east, head to Vegas, and if you hit the Claremont colleges, you've gone too far. So I had to go to Santa Monica every day, Monday through Friday, for 6 weeks. And I drove myself every day. And that can be anywhere from, a 2-hour drive to a 3-hour drive. COVID, no, 1 hour, door to door, 85 miles an hour on the 10 freeway. If I could have picked a time to have radiation therapy in Santa Monica, it would have been when I had it, yeah.
Maybe you can talk a little bit about somebody comes in, you give them the diagnosis, everyone hears the word cancer and it scares them because it's just that word that everyone hates. And then you sort of watch them deal with going through the process of accepting it, and then maybe some of them are like, well, I'm just going to keep doing my life, but then the reality steps in. So maybe you could talk in a little bit about sort of the reality of what you see in your patients as they go through the process.
I think the important thing to understand as a physician treating patients is that every patient is very different. They're going to be different with their preferences. They're going to be different with the things that are important to them in life. And you have to hear them, listen to that, and then figure out how to work with that. All the while, like, managing to things that you think within safety, right? Counseling them for what things and what timelines are safe. Like you mentioned, cancer can be very disruptive. It doesn't listen to what your plans are. It doesn't listen to you're going here, you're going there, you're going to do this, you're going to do that. It's going to do what it's going to do regardless of what your plans are.
Yeah, like when I was on the Lenvima, I had a trip to Japan scheduled, and one of the side effects I had was I had really bad trouble eating. I had almost total anorexia. I dropped a ton of weight. Nothing was appealing, and I had mouth sores, and I had this trip to Japan, and I asked my doctor can I take a break from this? I would like to be able to taste the food in Japan. I don't want to fly to Japan and not be able to eat anything. And it took a little back and forth, but then he said, yeah, you can stop it for a month. And it didn't completely alleviate the side effects, but it did lessen them enough that I could actually eat some food in Japan and actually taste it. And then when I got back, I was taken off the meds anyway because of toxicities. But that was, really helpful, because one of the things for patients, cancer patients and doctors to realize is that I hear a lot of patients in support groups and things saying, well, when this is over, then I'm going to. For those of us with recurrent cancer, there may never be a when this is over. So I have to live my life through this. I can't wait. Besides the fact that I'm old, I can't wait until this is done, because it may never be done. So I have to work with all of my doctors to say, this is what I want to do. This is how I want to live my life. And in some cases, we're going to have to bend treatment around my life versus me bending my life around treatment.
Absolutely. I think that's something that comes to the forefront, especially when you do have cancer and you realize, hey, my life could be much more short than I thought that it was going to be, right? I think that's a huge realization, and quality of life is very important. Seeing people you need to see is very important. Getting to have experiences that you want to experience is also very important. And so, yes, sometimes treatment is important if we know it's going to be working and we know it's going to be doing something, but we don't know that, especially in recurrent cancer. You don't know that the treatment you're going to give is working, and it has toxicities. And you need to make that allowance for your patients as part of their treatment of themselves as a whole, not just treatment of their cancer, treatment of their cancer, treatment of their cancer. You need to think of your patient and what their actual needs are. And I think, giving a break in treatment to go somewhere is very important. Thinking about, hey, how can we get this person to their planned vacation safely? And I think considering that, trying to arrange things around that is also very important.
All right. Evidence-based. Tell us about it.
Evidence-based. There's so much going on now with medical research, but there's also so much going on with misinformation, with social media influencers. Nobody trusts doctors anymore. No one trusts research anymore. The age of, I did my own research. I want to see your clinical trial results. So this was just a reminder that focus on the evidence-based research when it comes to your treatments.
Okay.
This one is a tribute to my first medical oncologist, Dr. Margolin. She runs the melanoma program at St. John's in Santa Monica. Because she runs the melanoma program, she also runs the infusion center. So at some point in time, I was her only GYN patient. All of her other patients were melanoma patients. And, I just saw her going out of her way to research articles for me, and she used to teach at City of Hope, so she'd be calling her colleagues and saying, what should I do with this one here, So this is actually a piece about melanoma, which was, for eons, just an absolutely deadly disease once it spread. And so it starts with all the melanoma spots, and then you can see the journal articles, the white journal articles come in, and the more and more research and amazing treatments. And I have a history of melanoma in my family, which I don't have to worry about anymore because I've already been treated for melanoma because it's the same treatment I got for endometrial cancer, which is the immunotherapy. This one is Pearls of Wisdom. Again, this is about medical research and just waiting for those little pearls to drop out of all that research, reading the studies like that, that one. Like for a long time, I was on the Keytruda-Lenvima combination, and it was always thought that if you couldn't tolerate the Lenvima or you finished the Lenvima, you couldn't ever go back on it again. But now there's a new study that says, well, no, if your cancer recurs, you could actually go back on the Lenvima again, and it actually does work again. It's miserable, but it does work. So it's about those little pearls you get out of the research.
So how do you keep up on all the new research? You just read journals? Do you go to courses? I mean, it seems like there's an amazing amount of new stuff about cancer popping up all the time.
I mean, thank God that it is. But yeah, it is a fast pace of new things that are coming out. I think it's a little fortunate. I don't know how medical oncologists do it because aside from subspecializing in certain cancers, but there's so much to know and so much that's coming out and so much targeted therapy and so much new immunotherapy and different combinations of things that, I think belonging to an organization, like for us, our organization is Society of GYN Oncology, and going to meetings when you can is helpful. Going to different talks about things. It's helpful just being in academia because you are kind of surrounded by it and you have your colleagues are reading something, they give that to you. One of our colleagues does a lot of research and he sends us articles all the time of things that are important and new things that are coming out. And so it is hard to stay on top of that. And I think it's particularly hard if you're a community doctor or if you're in practice by yourself and you don't have those resources. But at least sometimes our society will send us like emails that have new, kind of a list of the abbreviated stuff or the new stuff that's coming out. But yeah, it's a lot, especially when you're just about to study for boards and going through all those things. But it is important to stay on top of it because you want to be able to offer those things.
So for these guys, when they try to figure out where they want to do their internships and stuff, you mentioned a little community clinic versus here. Like, what do you have access to here that if they go to a rural clinic, the difference in how somebody would be treated walking into your office and they're bleeding?
Yeah. I mean, I think it depends on what your resources are at those clinics. And so, some smaller places might not have an infusion center. Here at USC, we have access to libraries, access to journals, and that kind of comes with working here, right? So it is easier to access those things, whereas sometimes you'd have to pay for those journals or you'd have to go out of your way to get them, go out of your way to get to meetings. We have routine educational sections, routine tumor boards where we get to interact with our colleagues a lot more. And so from an educational standpoint, it's a little bit easier. Not to say that you can't do all those things and you can't have all those things in smaller community settings. You definitely can. It's just a little bit harder to seek out.
Well, Karen loves journals. We know that already. All right, tell us about this piece.
This piece started out very differently than it ended up, not in terms of the look of it, but what it was intended to portray. So I was thinking about doing a piece about how cancer just rips through your life. So the band across the lower part is actually a portion, not the entire thing, a portion of the package insert of the one of the drugs I was on, Lenvima, which is a tyrosine kinase inhibitor. And it is literally 56 inches long when you open up this package insert with all of the things that it can do to you that are bad. And so I actually had to cut it off. The panel was shorter than the piece of paper. So it was intended to show how everything, cancer rips through your life. And so I started printing out little photos from my Instagram feed. And as I was putting it together, the whole point of the piece changed. I came to see how much I've done in the 5 years between when I was diagnosed and when I made this piece. I did a lot of living in those 5 years. There were trips in there and art openings and playing with the dogs and so it really was a change in perspective to me to say, this wasn't 5, wasted years of cancer treatment. This was 5 years of living with cancer treatment thrown in.
All right. So this is the most recent piece. So this was a piece that was done, and we talked about it, and you added a new panel to it, or you changed one to put it in the show. So talk about this piece. And if anybody has any questions, we'll take some questions right afterward.
So this is a piece I did that basically reflects the life cycle of a woman, any woman, but it incorporates a lot of my life in it. So it goes from, birth at the bottom there and circles around, and childhood and adolescence and work and travel and office. That poor crow in the cube farm, that was me. And it was intended. Well, the original focus of the piece was about the patriarchy and how would all of these things be different if we had a true matriarchy, not just women in our current structure of civilization, but a civilization structured on the female versus the male. And then when Ted and I were talking about adding this piece to the show, he mentioned that, well, this is the cycle of your life. You've got nothing in here about your health issues, your cancer. And I was like, you're right, I don't. And so I made a new panel for the bottom there, the dead crow, set against a picture of me getting a radiation treatment. But it has been a big part of my life. I mean, not only from my treatment, but I've spent my entire life working in healthcare. So it's, and I think we're seeing that as cancer becomes more of a chronic disease. And, as an oncologist, a lot of oncologists came up in the time when you got a new patient, either they died or the treatment was successful, and maybe you did monitoring for 5 years, and then you discharged them out to their general practitioner, and that was it. You never saw them again. Cancers now are becoming more and more of a chronic illness. And that's not only a shift for patients, it's a shift for doctors. I mean, if you wanted to follow a patient for 40 years, you would have gone into endocrinology, but now you're going to have more and more patients. If you go into oncology, you're going to have more and more patients where, okay, it's popped up again, we'll treat it with this, whack them all, and 3 months later, a year later, whack another mall. And you're going to be following these patients for years. And that's a big mind shift for physicians as well as patients.
So we'll end with this, and you get to make your pitch of why your specialty is a good career for these guys and why you chose it.
I think GYN oncology specifically is a very unique specialty in that, like we were just talking about, continuity and developing relationships with patients. That is a big feature of our specialty. And so a lot of people go into OBGYN in general because of the continuity that they get with women over their lives, because of their relationships that they develop, and honestly, because of all of these moments that you have with women. I mean, as a general OBGYN, during pregnancy, during follow-up, you see them during very special times of their lives. As a GYN oncologist, you see your patients during very scary times of their lives. Like I mentioned earlier, you meet them when they have this cancer diagnosis. They come in, they talk to you. Hopefully you alleviate some of their fears and give them an idea of a path forward. But then what starts to be even more unique is that, we talk to them about surgery. We do their surgery. We see them after their surgery. We go over their pathology. We go over their treatment plan, if there is one that follows. We are usually the person that sees them through chemotherapy. After they're done with chemotherapy or radiation, we're the person that sees them and does their exams and their follow-up visits and sees them whether it's every 3 to 4 weeks on chemo, or it's every 3 months, 6 months when they're now under surveillance and have no evidence of disease. But you are with that person. I tell my patients after they're done with their surgeries, or when they, if they have a cancer diagnosis, I'm like, you're my friend now. Like we're friends, and we're gonna make sure we go through this together. But you see them more often than their primary care doctor. Sometimes they see you as the person that they trust most or the doctor that they trust most. And so it is a very deep relationship that we end up developing with our patients. More so than, honestly, in medical oncology and more so than in surgery, because most surgeons see their patients and then, they're done, they've healed, it's over, and they discharge them. So we see them all the way through the end. Sometimes we see them and we see them with their families. If unfortunately they do pass from cancer, we see them in that time too. And we work with them in the palliative setting and with palliative care and kind of guiding them through that process as well. So there's a lot of emotions that we deal with. It can be an emotionally strenuous career. There's a lot of follow-up, but it is extremely rewarding for those reasons.
I've never asked any other doctor this, but if you've been dealing with someone for a while and they die, do you ever go to the funerals, or do you keep that separate?
It depends on if they invite me, if their families invite me. I've gone to a few funerals, and sometimes it helps give you a little bit of closure, which is good. There's never any real closure. But there's always some sad stories that come through, and I think, when invited, if I'm able to go, I try to go.
Are there any questions for our panel? Yeah.
I tend to take a long time to process these things, so I didn't start making this art until probably the end of 2024, and I was diagnosed in 2020, but once I started it, I couldn't stop it. And being able to come home, say, from radiation treatment or a scan and go out to my studio and make work about my experience was really, really very helpful in the whole process of going through treatment and recovery. Knowing that I could, do that and focus and it just became part of the process. It was really very, very helpful for me and very healing to do that. Yeah, it wasn't as much turning something painful into beauty as it was expressing, for me, it's a lot of the absurdities of medical care, of cancer care, of the whole healthcare system. You're just running into absurdities like all the time, and helping me process that. Like the weird thing the doctor says when he's got you on the table, and the and waiting for scans and doing being able to process those emotions through my artwork, and still make it something that might be visually appealing, and that other patients or other people could just look at that and say, oh yeah, I get that feeling from this piece. Thank you. Yeah, there's I thought I'd had a third recurrence. There was some suspicion I'd had a third recurrence about 6 months ago, and so they scheduled my PET scan. And I call scheduling, and they can't get me in for 6 weeks. And I'm like, this is not acceptable. And I'm calling my previous medical oncologist in Santa Monica and saying, can you get me a PET in Santa Monica? And so finally I had it figured out. But, first of all, patients should not have to do that. We should not have to be calling to schedule our own exams. Someone should be doing that for us. But the anxiety that goes around it, people don't think about it. Oh yeah, well, PET scanner's full. We can't get you in for 6 weeks. No, that doesn't go over well.
Yeah, not to mention insurance authorizations and all of the other roadblocks with those things.
My oncologist did a happy dance when I became Medicare eligible and got good old-fashioned fee-for-service Medicare, and she didn't have to get authorizations anymore.
All right. On that note, we have a minute left, and I will let Dr. Schaff finish up.
Thank you. So first of all, a huge thank you, Karen, for sharing your beautiful work with us, and for Dr. Ciccone joining us with your expertise. I think one of the things I want, especially for our first-year students, is to recognize the stories that your artwork tells. I love that you have not only the images, but the words and the stories that support and sort of convey your experience. And Dr. Ciccone, you said something that is really important, which is that every patient is different and that you need to listen and to hear what is being shared with you. And on Monday, in our session in EPIC on narrative humility, we're going to continue to talk about that, and we'll actually be talking about how we can get better at listening. So you set us up beautifully for that. And thank you again for everything. Ted, thanks for great moderation.